Welcome to the Deep Dive, where we meticulously unpack complex topics, giving you the shortcut to being truly well informed. Today, we're plunging into a subject that's incredibly common in orthopedic practice and sports medicine, yet often surrounded by confusing terminology. Things like a twisted ankle or a pulled muscle. We've all encountered them, haven't we? Whether in clinic or maybe even on the pitch ourselves. And understanding the nuances is absolutely critical for effective patient care. Our mission for this deep dive is to thoroughly unpack the intricacies of diagnosing and managing sprains, strains, and tears. We really aim to provide a comprehensive, expert-led discussion tailored specifically for you, our mid-senior medical professionals, moving beyond just surface-level understanding into clinically actionable insights. And to guide us through this complex anatomical landscape, I'm delighted to welcome our expert guest today. Your distinguished expertise in orthopedics and sports medicine is renowned, and we're so pleased you're joining us for this deep dive.
Well, it's a pleasure to be here. This is such a fundamental topic, isn't it? It impacts so many of our patients, from, elite athletes right through to the everyday individual. So getting a clear understanding is paramount for anyone in orthopedics. Getting this right from the outset really makes a profound difference to recovery outcomes.
Definitely. So let's start unpacking this. We often hear the terms sprain and strain used almost interchangeably, perhaps more colloquially, but in clinical practice, they refer to very distinct injuries affecting specific anatomical structures. How do you typically clarify those precise anatomical differences for, say, junior colleagues or students?
Right, that distinction is absolutely fundamental. Okay, let's start with the sprain. This refers specifically to an overstretching or indeed a tearing of ligaments. And it's crucial to remember that ligaments are those tough, fibrous bands of tissue that connect bone to bone at a joint. Their main job is to provide stability. Think of them as the joint's sort of internal guide ropes or seatbelts.
Okay, bone to bone, got it.
Precisely. And where do we commonly see sprains? Well, the ankle is the absolute classic example, the typical rolled ankle injury. That's almost always a lateral ankle ligament sprain. But we also see them very frequently in the knee, particularly things like anterior cruciate ligament or ACL injuries. Sprains of the wrist are common too. And the thumb, think of a skier's thumb. That's the ulnar collateral ligament.
Right.
Now, in contrast, a strain involves the overstretching or tearing of muscles or their associated tendons. And tendons, as you know, are those dense fibrous cords connecting muscle to bone. Their function is all about facilitating movement. They're the ropes that pull the bones, effectively.
Okay, so muscle to bone for strain.
Exactly. So we typically find muscle strains in large, powerful muscle groups. Think hamstrings, the muscles of the back, the calf muscle, the gastrocnemius. And for tendon strains, on examples would be the quadriceps tendon just above the knee, or perhaps the rotator cuff tendons in the shoulder.
That distinction really crystallizes it. It's fundamentally about which soft tissue is affected bone-to-bone ligaments for sprains versus muscle-to-bone tendons or the muscle belly itself for strains.
But what about tendinitis? We hear that term a lot too. Is that also a type of strain, or is it something else entirely?
Ah, that's vital clarification, actually, as it's often confused. So unlike a true strain, which involves that overstretching or actual tearing of muscle or tendon fibers, tendinitis is primarily inflammation within the tendon itself. Critically, there's no acute tearing of the fibers involved. It's typically an overuse issue, you see, a result of repetitive microtrauma and irritation rather than a single acute traumatic event causing a tear.
Okay, so more chronic, less acute tear.
Precisely. And understanding this distinction is crucial because tendinitis often requires different management considerations. You're focusing on reducing inflammation, addressing the underlying biomechanical overload, whereas a strain demands a focus on tissue healing and repair of the torn fibers, different pathways. Right, that makes sense. So the term tear then, does it simply refer to a more severe grade of either a sprain or a strain? Is it just a descriptor of severity rather than a separate category?
Exactly. Spot on. Tear is often the sort of colloquial term we use to describe a more significant injury, whether it's to a ligament or a muscle tendon unit. It really exists along a continuum of injury severity. The spectrum ranges from, minor microtraumas, essentially microscopic stretching injuries, where only a few fibers are affected, right through to partial tears, where a decent portion of the tissue is disrupted. And then at the most severe end, you have a complete rupture or even an avulsion where the tissue is fully torn, often right off its attachment point on the bone.
I see.
So yes, both sprains and strains can exist anywhere along the spectrum, from a really mild stretch with minimal fiber damage right up to full tissue disruption. And that's precisely why an accurate diagnosis of the specific tissue involved and the degree of its disruption is so incredibly important for prognosis and, of course, for guiding treatment.
With those definitions clear, let's turn to the mechanics. How do these distinct injuries typically happen in our patients? What's the how behind a twisted ankle or a pulled hamstring in practical terms?
Right, the mechanisms.
Yeah.
We can broadly categorize them into direct trauma and indirect trauma.
Yeah.
Direct trauma is fairly straightforward. It's when an external force is applied directly to the muscle or joint.
Hmm.
This leads to injuries like contusions, which are essentially bruises, deep bruises sometimes, or even lacerations from impacts or sharp surfaces. Think of a direct kick to the thigh in football, causing a quadriceps contusion, a dead leg. However, indirect trauma is far more common, particularly in non-contact sports. And importantly, it involves no external traumatic force acting on the body. The primary driver here is often eccentric muscle contraction. Now, this is a really critical point. Eccentric contraction occurs when the muscle lengthens under tension while simultaneously trying to contract.
Right, like lowering something heavy slowly or when your foot hits the ground running.
Exactly. Imagine lowering a heavy box slowly, or crucially, decelerating during a high-speed run. These eccentric contractions generate significantly greater forces compared to isometric contractions, where the muscle length doesn't change, or concentric ones, where the muscle shortens. This inherent characteristic of eccentric contraction markedly increases the risk of injury, because the muscle is essentially being pulled in two directions at once, lengthening while resisting a load.
That makes sense. High forces involved.
Very high forces. And to give you specific examples, hamstring injuries are notoriously frequent during that eccentric phase of high-speed running. The hamstrings are lengthening under immense tension to control the forward swing of the leg just before the foot strikes the ground. That's a classic moment for a tear. Similarly, the quadriceps and the gastrocnemius muscles in the calf are also highly susceptible, often because they're multi-joint muscles, crossing both the hip and knee, or knee and ankle. And they're heavily involved in powerful eccentric activities, think landing from a jump, or those sudden changes in direction you see in basketball or football.
Okay. And beyond specific muscle actions, what about simple accidents?
Yes, injuries also frequently arise from sudden incidents. For instance, someone breaking a fall with an outstretched arm that's a classic mechanism for a wrist sprain, as the ligaments are suddenly overloaded. Twisting a joint unnaturally, perhaps stepping awkwardly off a curb, or landing badly from a jump that frequently leads to an ankle sprain. A direct blow, as we mentioned, could cause a contusion. An improper technique when lifting heavy objects, lifting that heavy filing cabinet in the office, perhaps is a very common cause of a back strain, as the muscles are suddenly overloaded beyond their capacity.
And what about things that build up over time? Repetitive strain.
Yes, absolutely. We also see injuries resulting from repetitive overuse. This is where the cumulative demand from intense, repeated activities can lead to pain that might feel sudden in its onset, but has actually been building gradually over time. A classic example is tennis elbow, or lateral epicondylitis. Despite the name, it isn't just limited to tennis players, is it?
No, you see it in golfers, tradespeople.
Exactly. Golfers, carpenters. It's due to the constant irritating stress on the forearm tendons from repetitive gripping or twisting movements. Another common scenario is a calf strain developing in a marathon runner. The cumulative mileage, the repeated stress, eventually leads to the injury, often seemingly triggered by a sudden acceleration or hill climb.
Right.
And finally, it's really worth highlighting that a pre-existing lack of flexibility or perhaps strength in the supporting ligaments, muscles, and tendons can significantly predispose individuals to these types of injuries. If the body simply isn't adequately prepared to absorb and dissipate the forces applied during activity, well, something has to give, doesn't it?
That detailed breakdown of injury mechanisms is incredibly helpful for connecting the patient's story to the likely pathology. Now, for us clinicians, accurately grading these injuries is fundamental. It guides prognosis, determines treatment pathways, and ultimately helps set realistic return to activity timelines. Could you walk us through the established classification systems for both sprains and strains, and perhaps shed some light on the more nuanced approaches that are gaining traction, especially in sports medicine? Does that extra detail really change things in practice?
Absolutely. The classic grade Crazy or 3 system remains the cornerstone, really. It's used for classifying both ligamentous injuries, sprains, and musculotendinous injuries, strains. It provides a clear, pretty universally understood framework for describing the severity. So let's break it down. Grade I, mild. For a sprain, this means stretching of the ligament fibers, maybe very mild micro tears, but crucially, there's little or no instability at the joint. Clinically, you typically see minimal pain, perhaps slight swelling, localized tenderness on palpation, but with a relatively normal, stable range of motion. You might see a patient with a mildly swollen ankle after a slight twist, but they can still bear weight, albeit with some discomfort.
Oh.
For a strain, a grade I involves damage to only a few muscle fibers. It presents with slight edema, some discomfort, there's minimal loss of strength or limitation of movement, and typically no palpable muscle defect. Now, for athletes, it's absolutely crucial they cease activity immediately upon feeling this kind of twinge to prevent the injury from extending into something worse. A common scenario here might be a minor twinge in the hamstring during a sprint, which causes discomfort but doesn't immediately stop them in their tracks.
Right, nip it in the bud.
Precisely. Then we have grade 2, moderate. A sprain at this grade represents a more serious but still incomplete tear of a considerable portion of the ligament fibers. This results in some noticeable looseness or moderate instability in the joint. Patients will experience more significant pain, often with visible bruising and considerable swelling. There's also moderate functional limitation, and quite often, a distinct pop sensation may have been reported by the patient at the time of injury.
So they'd struggle to bear weight, perhaps?
Yes, often. Imagine a patient with a significantly swollen and painful ankle who struggles to bear full weight, and clinically, you can elicit some laxity on stress testing compared to the other side. For a strain, grade 2 indicates greater damage to the muscle or tendon with evident loss of function, meaning the ability to contract the muscle effectively is impaired. A small, but often palpable muscle defect or gap may be present at the injury site. You'll typically see a slight local hematoma and possible ecchymosis, or bruising, developing within maybe 2 to 3 days. Healing for the muscle tissue itself usually takes around 2 to 3 weeks, with a gradual return to physical activity typically possible after about 1 month with proper rehab. Here, an athlete might pull up sharply during a run, with immediate sharp pain and difficulty continuing.
Okay, clear difference there.
Yeah.
And grade 3.
Grade 3, severe. This is the most severe grade. For a sprain, it means a complete tear or rupture of the entire ligament. This leads to a truly loose and very unstable joint. Patients experience intense pain, significant swelling, and often extensive bruising, which can sometimes appear quite distant from the actual injury site, tracking down with gravity, as you know. An audible pop is very commonly heard or felt at the time of injury. Functionally, it's often impossible for the patient to put weight on the joint or use the affected limb effectively. Think of a complete ACL rupture where the knee feels completely unstable, or a severely dislocated joint after a major ligamentous avulsion.
A major injury.
Definitely. And for strain, a grade 3 injury signifies a tear extending across the entire cross-section of the muscle, or a complete tendon tear. This results in virtually complete loss of muscle function and intense pain. There is evident failure of the muscle structure. Sometimes you can see a visible deformity, like a gap or bulge where the muscle has retracted. Ecchymosis tends to be extensive. Healing time for these severe injuries ranges from 4 to 6 weeks just for initial tissue healing, requiring intense rehabilitation for extended periods, sometimes up to 3 or 4 months or even longer, with the potential for persistent pain or functional deficits even months after treatment.
Right. Now, you mentioned more nuanced classifications, particularly for muscle injuries.
Yes, that's right. While the grade 3 system is foundational, contemporary literature, particularly coming out of sports medicine research, has introduced more nuanced muscle injury classifications. These go beyond the simple 3 grades and are especially useful for professional and high-level athletes. They allow for more precise prognostication and help tailor management much more specifically. For our listeners in orthopedics, understanding this deeper level of granularity can really refine your approach, especially when dealing with high-demand patients or perhaps more complex or recurrent cases.
Okay, so what do these look like?
Well, one commonly cited system, sometimes referred to as the British Athletics Muscle Injury Classification, includes grades from 0 up to 4. Grade 0 describes a focal muscle injury but with a normal MRI. Here, the patient reports a specific awareness of the muscle with use, and there's localized tenderness on palpation, but surprisingly, standard imaging may still appear normal. Clinically, it's like a pre-injury warning sign, perhaps, a tightness that feels like it might escalate.
Almost subclinical on imaging.
Exactly. And grade 0B is essentially generalized muscle soreness with a normal MRI, what we commonly call DOMS, delayed onset muscle soreness. There's no identifiable acute trauma. Muscle pain usually starts 24 to 48 hours after unaccustomed or very intense exercise with widespread tenderness. Again, MRI often appears normal. This is the marathon runner feeling stiff all over the day after a race rather than having a specific sharp pain.
Okay.
Grade 1 involves small local tears to the muscle. The patient will recall a noticeable moment of injury with immediate pain and localized tenderness. There's no significant loss of range of motion, but some limited loss of muscle power may be present. This is a clear structural injury, but minor. Grade 2 indicates moderate localized tears. This involves a more pronounced, noticeable moment of injury, immediate sharp pain, and often very localized and specific tenderness on palpation. There's still generally no loss of range of motion, but there's a moderate loss of muscle power and moderate functional limitation. The tear here is usually clearly visible on imaging like ultrasound or MRI.
Getting more significant?
Yes. Grade 3 describes extensive tears to the muscle. Again, a noticeable moment of injury with immediate and significant pain, marked localized tenderness. Patients may present with some loss of range of motion, a significant loss of muscle power, and significant functional limitation. These are often large partial tears involving a substantial portion of the muscle cross-section. And finally, grade 4 is the most severe. Complete tears to the muscle belly or the tendon, or critically, at the junction between the muscle and tendon. There's a noticeable moment of injury, immediate dull, oppressive pain, often accompanied by a distinct snapping sensation, and immediate functional disability. On examination, there's often localized tenderness, with a visible deformity to the muscle that's sulcus or gap. There can be some loss of range of motion, significant loss of muscle power, and severe functional limitation. The function of the musculotendinous unit is essentially lost, and a hematoma develops early and is often extensive.
That granular classification, especially 0A through 4, seems really geared towards understanding subtle differences and predicting return to play, particularly in elite athletes, doesn't it? For our listeners, perhaps in a busy general orthopedic clinic, what's the single most critical insight you'd want them to take from these nuanced systems? What really changes their immediate management or referral decision, perhaps beyond what the simpler Great Earth tells them?
That's an excellent point. Practicality is key. Look, for most general orthopedic settings, the grade O3 system remains perfectly adequate for broad management decisions. It works. However, the critical insight, I think, from the more nuanced classifications, especially those grade 0A and 0B, is the concept of identifying these pre-injury states or very subtle structural changes. Changes that don't necessarily show up on standard imaging, but are definitely causing symptoms for the patient.
Oh, okay. The symptom without the obvious sign on the scan.
Exactly. For a high-level athlete or even just a keen weekend warrior who's suddenly experiencing unexplained soreness or this awareness without a clear traumatic event, these grade 0 injuries highlight that symptoms aren't always indicative of a significant tear. It's a call to look deeper, doesn't it? Look at their training load, their biomechanics, their recovery strategies, rather than just dismiss it as general soreness. It really prompts us to consider more conservative, perhaps preventative interventions earlier, potentially averting a full-blown grade 1 or 2 injury down the line. And it also underlines that crucial point. Normal imaging doesn't always rule out a problem for a symptomatic patient. It forces a more holistic view, considering the patient's activity and potential predisposing factors.
That distinction between overt injury and perhaps pre-injury or subtle pathology is a really vital take-home message. Thank you. Now let's go even deeper if we can. What exactly is happening at the cellular and tissue level when a sprain or strain occurs? And how does the body, in its remarkable complexity, actually attempt to heal itself? This is where it gets truly fascinating for the medical mind.
Right, this delves into the intricate physiopathology. And first, it's crucial to understand a fundamental difference between muscle and, say, bone healing. Muscle healing is primarily a repair process. That means fibrous scar tissue forms to bridge the gap. Whereas in bone tissue, for instance, it's largely a regeneration process, aiming for, ideally, restoration of the original tissue structure.
So muscle doesn't quite get back to its original state.
Not perfectly, no. That distinction has significant implications for functional recovery. We're often aiming for a functional scar, one that's strong but pliable, rather than perfect tissue restoration. Now, skeletal muscle healing, regardless of whether it's from bruising, a sprain, or a laceration, follows a remarkably consistent three-phase order. These phases are distinct, yet they overlap and are very closely interrelated.
Okay, what are the phases?
The first is phase 1, destruction. This phase kicks in immediately upon injury and typically lasts for maybe 1 to 3 days. It's characterized by the initial tearing and subsequent necrosis, that's cell death, of the myofibrils, the contractile units of the muscle fiber. This destruction is immediately followed by the formation of a hematoma, essentially a blood clot, which fills the space created by the torn muscle. Think of it as the body's immediate attempt to plug the leak.
The initial inflammatory response.
Exactly. Within the first day, there's a rapid proliferation of inflammatory cells, phagocytes, neutrophils, which invade this hematoma to begin organizing the coagulum and clearing out the damaged debris. It's the cleanup crew arriving. And crucially, during this phase, there's the presence of a specific structure called the contraction band.
Contraction band.
Yes, it's fascinating. It's a condensed area of cytoskeletal material that forms at the ends of the surviving muscle fiber stumps. It acts as a sort of biological firewall system. Its remarkable role is to limit the spread of necrosis along the length of the muscle fiber, thereby preventing more extensive damage than the initial tear caused. It effectively seals off the healthy tissue.
Wow, a protective mechanism right at the cellular level.
Precisely. Now, as the destruction phase begins to diminish, usually within 48 to 72 hours, we move into phase 2, repair and remodeling. These two processes, repair and remodeling, happen almost simultaneously and are closely interrelated, almost competing with each other in a way. This phase can last from a few days up to several weeks, depending on the injury's severity.
Okay, what happens during repair?
Well, on one hand, you have the regeneration of the torn myofibrils. The remarkable regenerative capacity of skeletal muscles is ensured by an intrinsic mechanism involving satellite cells. These are quiescent, undifferentiated reserve cells, lying dormant just below the basal lamina surrounding each myofibril. In response to the lesion and the inflammatory signals, they activate. They proliferate, differentiate into new myoblasts, and then fuse together to form multinucleated myotubules. Their aim is to restore the injured contractile apparatus, essentially trying to rebuild new, functional muscle tissue.
So the body tries to regenerate muscle tissue?
It tries, but concomitantly, at the same time, there's the production of connective scar tissue, fibrin from the blood clot and fibronectin crosslink to form granulation tissue. This provides an initial scaffold, anchoring fibroblasts to the cells that produce collagen to the site. This early scar tissue offers crucial early tension resistance against muscle contractions, protecting the regenerating fibers. It's the framework for repair.
A scaffold, right.
And during this phase, there's also the vital neoformation of blood vessels, or vascularization. New capillaries grow into the area, which is an absolute prerequisite for subsequent morphological and functional recovery, bringing in oxygen and nutrients and taking away waste products. Neural growth also begins here, starting the slow process of reestablishing nerve connections.
Okay, so regeneration and scar formation happening together.
Exactly. And that leads us to phase 3, remodeling. This is the maturation phase, which can extend for many months, even up to a year or more for severe injuries. Here, the newly regenerated myofibrils mature and integrate. The connective scar tissue undergoes contraction and reorganization, becoming stronger and more aligned along the lines of stress. Over time, the scar tissue typically reaches a point where it is no longer the most fragile part of the muscle injury, often around 10 days after the initial traumatic event. This is a key milestone, as it allows for more progressive loading and rehabilitation. This whole phase is about the gradual recovery of the overall muscle functional capacity, where the scar tissue becomes more organized, more functional, and hopefully less restrictive.
It sounds like a delicate balance.
It absolutely is. It is paramount to emphasize the critical importance of a balanced progression between that myofibril regeneration attempt and the necessary scar tissue formation for optimal recovery of muscle contractile function. If there's excessive proliferation of fibroblasts, for example, perhaps due to prolonged inflammation or improper loading, it can lead to the formation of dense, disorganized, non-functional fibrous scar tissue within the muscle lesion.
And that would be bad.
Very bad. That dense scar tissue can significantly impair long-term function, leading to persistent weakness, reduced flexibility, pain, and importantly, an increased risk of re-injury at the same site. Think of it like this. Your body isn't just gluing the muscle back together, it's trying to rebuild. But if it over-repairs with stiff, disorganized scar tissue, that muscle just isn't going to perform like it used to. The goal of good management and rehab is really to guide this process towards a scar that is strong, yet pliable, allowing for maximal restoration of muscle integrity and function. It's a fine balancing act.
That deep dive into the cellular and tissue-level response is incredibly illuminating. It paints such a vivid picture of the healing process and that critical balance between regeneration and scar tissue. So knowing what's happening inside, how do we as orthopedic clinicians translate that cellular understanding into a thorough clinical assessment for a suspected sprain or strain? What specific details should we be meticulously gathering and looking for in the clinic?
Indeed, the clinical assessment is absolutely where it all begins. You can't manage what you haven't accurately diagnosed. The diagnosis of a muscle injury or sprain inherently starts with obtaining a really detailed clinical history of the trauma. You need to be a bit of a detective, asking the right questions to understand the precise nature and context of the injury.
So what are the key questions?
Right. Key questions to ascertain include: First, the onset of symptoms. Did the pain begin gradually, perhaps after an increase in training load or some unaccustomed activity, or did it appear suddenly after a specific, identifiable injury event? This distinction is crucial. Gradual onset often suggests overuse, maybe tendinitis, while sudden onset points much more strongly towards an acute tear. Then you must inquire about any prior injuries to the affected area. A history of previous sprains or strains is a significant risk factor for re-injury, isn't it? It can strongly influence your diagnostic suspicion, highlighting areas of potential chronic weakness or instability.
Yes, previous injury is a huge predictor.
Absolutely. Next, ask about activities requiring repetitive use of the joint or muscle. So if it's an elbow injury, you might ask about things like hammering, prolonged computer use, swimming, specific sports. These can help pinpoint the likely affected structures, like the common extensor or flexor origins. Understanding their specific sport or occupational demands is equally vital for other joints and muscle groups. For contusive or direct impact injuries, try and note if the pain onset was immediate and, importantly, if the symptoms increased over time, particularly in correlation with the apparent size or entity of a hematoma. This might indicate ongoing bleeding or significant tissue damage. For those potentially non-structural injuries where there might not be an obvious tear, ask about more general symptoms like muscle soreness, a feeling of heaviness or stiffness. Note if it increases with exercise or if it's present even at rest. And specifically for delayed onset muscle soreness, DOMS, what we class as a type 0B injury, clarify if the pain occurred hours after unaccustomed intense activity and if the whole muscle feels stiff rather than a sharp, localized pain point. For potential grade 2B injuries, inquiring about muscle cramps and whether stretching improves symptoms can sometimes be indicative of muscle spasm and overload rather than a frank tear.
Right, teasing out the exact nature of the pain.
Precisely. Then, following that detailed history, a systematic physical examination is absolutely indispensable.
What are the key components there?
Well, you start with inspection. Visually assess the injured area carefully. Look for obvious edema, swelling, and ecchymosis, or bruising. Remember, in severe cases, the bruising can appear quite distant from the actual tear site, tracking downwards due to gravity. A classic example is bruising appearing down the calf or even the ankle after a proximal hamstring tear near the buttock.
Yes, gravity takes hold.
It does. Also look for redness, warmth, which might suggest inflammation, and critically, any visible deformity. This is particularly important for severe tears. For example, that sulcusong, or a palpable gap in a quadriceps tear, strongly indicates a frank rupture, compared to the other side, always.
Comparison is key. Then palpation.
Palpation. Gently but thoroughly palpate the muscles and joints. You're trying to identify the exact point of maximal pain, localized tenderness, which is often sharp and very specific for structural tears, and any associated stiffness or perhaps crepitus. A key finding in grade 2 or 3 strains is the ability to identify a palpable muscle defect or a gap at the injury site. This confirms a significant fiber disruption. You're really looking for that exact tender spot that reproduces their specific pain.
And testing function.
Functional tests. Evaluate the patient's active and passive range of motion, ROM, of the affected joint. For an elbow injury, for instance, specifically assess bending, extension, and forearm rotation, noting whether these movements elicit or exacerbate their pain. Actively resisting their movements, resisted testing can often pinpoint the exact muscle or tendon involved. And it's also important to extend the examination to adjacent areas, the joint above and below, and sometimes the spine. Check the wrist, neck, and shoulder for elbow pain, for example, to rule out referred pain or concomitant injuries. Cervical radiculopathy, for instance, can easily mimic shoulder or arm pain. Good point. Strength testing.
Strength testing. Perform specific function tests, both with and without external resistance, to gauge muscle strength and identify any weakness in the injured area. Always, always compare your findings with the uninjured contralateral side for a reliable baseline. This can often differentiate a mild weakness due to pain inhibition from a significant loss of function due to a structural tear.
And finally, for sprains.
Joint stability. Yes. For suspected sprains, which affect the ligaments, you must meticulously assess the stability of the joint. Perform specific stress tests, like the anterior drawer test for an ankle or knee, or varus valgus stress test for the knee or elbow, looking for any laxity, excessive movement, or a sensation of giving way compared to the other side. This would indicate ligamentous compromise. That's a very comprehensive approach to the clinical assessment. Given that sprains and strains can sometimes present with quite similar symptom profiles, what are the crucial indicators during this initial assessment that should really raise immediate concern? The things that flag up a potentially more severe injury requiring urgent medical attention. What are those absolute red flags we must not miss?
Ah, yes, the red flags. These are clearly non-negotiables, aren't they? It truly underscores the importance of a thorough assessment, because missing one can have serious consequences for the patient. You must consider referring for prompt, often urgent medical care or further investigation if any of the following are present. Firstly, an inability to bear weight on the injured limb or significant difficulty moving the affected area. This immediately suggests a severe structural compromise, potentially a complete rupture, a significant fracture, or maybe even a dislocation.
Okay, inability to weight bear is major.
Absolutely. Secondly, clear joint instability, or the joint feeling loose or perhaps giving way during normal movement or testing. This points strongly towards a significant ligamentous tear, possibly a grade third, where the joint's inherent integrity is compromised. Thirdly, persistent difficulty moving the injured area or a significant loss of range of motion that doesn't improve with initial rest and management. This could indicate a large restrictive hematoma, severe muscle guarding, or even early adhesion formation.
Numbness or tingling.
Yes. Fourthly, numbness or tingling in any part of the injured area. This is a big red flag as it could suggest nerve involvement or compression, potentially from swelling within a confined space, like compartment syndrome or direct trauma to a nerve. Fifth, a history of recurring injuries in the same area. This indicates an underlying weakness or instability that hasn't been properly addressed. It requires proper assessment to prevent further damage. It's a red flag for chronic issues or perhaps improper initial healing that needs reevaluation.
Severe pain.
Sixth, severe, intense, or persistent pain that does not improve with appropriate rest or simple over-the-counter medication. This level of pain suggests a more serious underlying pathology or potentially an evolving complication like acute compartment syndrome. Seventh, extensive or worsening swelling and bruising. While some bruising is normal, rapid or spreading ecchymosis, especially if it appears distant from the injury site quite quickly, can indicate significant internal bleeding or vascular injury.
What about noises, pops or cracks?
Eighth, yes, hearing or feeling a distinct crack or pop at the time of injury, especially if the subsequent pain is directly over the bones of the joint. This is a classic sign suggesting a potential fracture or dislocation, or perhaps a complete tendon rupture. X-rays become crucial here. Ninth, any visible deformity or change in the shape of the muscle or limb. This is a strong indicator of a complete muscle or tendon rupture where the muscle belly may retract, causing that visible gap or bulge we mentioned. Think Popeye sign with the biceps rupture. And finally, any signs of infection. Things like a very high temperature, the patient feeling hot and shivery, or rapidly spreading redness, warmth, and tenderness around the injury site. This would warrant immediate investigation for potential cellulitis, septic arthritis, or abscess formation.
So those are the absolute stop signs.
They are indeed. These are the moments when a clinician must pivot from standard conservative management towards a more urgent diagnostic and therapeutic pathway, often requiring immediate imaging, specialist referral, or even hospital admission.
Okay, so when the clinical picture does require further clarity, perhaps after flagging one of those concerns, or just if a more serious injury is suspected, imaging becomes an indispensable tool. Could you detail the different imaging modalities we rely on and their specific roles in accurately diagnosing sprains and strains? Highlighting their strengths and limitations for our audience would be really helpful.
Certainly. Imaging techniques play a really important complementary role to the clinical examination. It's not usually a matter of one being universally superior, but rather understanding their hierarchy, their specific utility, and what unique information each one can provide to help confirm or refine the diagnosis.
So where do we usually start? X-rays.
Yes, almost always X-rays. Their primary role is really as the initial imaging modality. The main purpose is to rule out bone fractures or significant dislocations. They also help identify any underlying bone abnormalities, maybe loose bodies within a joint, or small avulsion fractures where a piece of bone has been pulled away by a ligament or tendon.
So primarily for bone issues.
Primarily. Now, they can show indirect signs. While X-rays don't directly visualize soft tissues like ligaments or muscles well, they can sometimes reveal indirect signs of sprains or strains. For example, an accumulation of fluid within a joint capsule, a joint effusion, might be visible as a subtle shadow. General soft tissue swelling can also sometimes be inferred, and calcification might be observed in certain chronic injuries, like long-standing tendinopathy. But their main limitation is that they offer very limited direct information about the soft tissues themselves. You simply won't see a muscle tear or a ligament sprain clearly on a standard X-ray.
Okay. What about ultrasound? That seems increasingly common.
Yes, ultrasound US has become a very powerful tool. Its role is often considered the method of choice for diagnosing superficial muscle injuries due to its accessibility. It's relatively cheap, fast, and often available right there in the clinic, and crucially, its dynamic capabilities.
Dynamic. How so?
Well, its key advantage is that it enables dynamic assessment. You can actually watch the muscle contract and relax or stress a ligament in real time, seeing how the tissues behave under load or with movement. This is a huge advantage over static imaging like X-ray or MRI for certain conditions. It provides clear images of superficial soft tissue structures like muscles, tendons, and ligaments. It's particularly useful for checking tendons for swelling, indicative of tendinitis, and can often reveal small tears or stretched ligaments quite well. Ultrasound can also help determine if an injury is acute or perhaps related to chronic overuse changes.
So very useful, especially in clinic. Any downsides?
The main limitation is that ultrasound is highly examiner dependent. The quality and accuracy of the diagnosis can vary significantly with the operator's skill and experience. It also has lower sensitivity for very minor injuries where there isn't much swelling or fluid, and it may not allow effective assessment of deeper tissues within the body, especially those obscured by bone or overlying structures. But it also has some advanced uses. Color Doppler and power Doppler ultrasound can visualize blood flow, which can be useful in depicting hypervascularity within scar tissue, perhaps indicating instability or ongoing inflammation. It's also highly reliable for ruling out deep vein thrombosis, DVT, in the calf, which is a critical differential for calf pain, as we discussed. And it's excellent for image-guided aspiration of fluid accumulations like large hematomas.
Right. So the gold standard for soft tissue is often said to be MRI.
Yes. Generally speaking, magnetic resonance imaging, MRI scan. Its role is considered the gold standard for detailed visualization of soft tissues. It excels at detecting injuries to deep soft tissue structures and also subtle bone injuries, like bone bruising or stress fractures that might not be visible on X-ray or even clearly on ultrasound. Its key advantages lie in the physics. It uses a powerful magnetic field and radio waves to create incredibly high-resolution images, offering excellent intrinsic contrast between different soft tissues without radiation. Fluid-sensitive sequences, like STR and T2-weighted sequences, are particularly brilliant, allowing detection of even minimal changes due to edema or fluid, which are early signs of injury. It's also panoramic, providing a wide field of view, which is great for evaluating deeper muscles that are difficult to study adequately with ultrasound, like the adductors or deep gluteal muscles. MRI can precisely define the location and extent of a lesion, including hematoma size and any musculotendinous retractions or avulsions, making it invaluable for preoperative planning if surgery is being considered.
When would you specifically opt for an MRI?
Well, typical indications include providing a more accurate prognosis for non-structural injuries, especially in professional athletes, confirming or excluding minor structural injuries when the clinical exam and ultrasound findings perhaps don't quite match up, assessing those muscles that are difficult to examine well via ultrasound, and definitely in cases of subtotal or complete muscle or tendon lesions where surgical intervention is contemplated, or when tendon involvement or bone tendon avulsions are suspected. Using contrast medium like gadolinium can also be useful for monitoring the stability and maturity of scar tissue after a structural injury, which can be critical for guiding return-to-play decisions.
And the limitations of MRI.
Its main limitations are that it is a static examination. Unlike ultrasound's dynamic capability, it captures a snapshot in time, not real-time movement. Also, the high sensitivity to fluid means the presence of liquid on MRI scans can sometimes overestimate the actual structural damage, so careful clinical correlation is always needed. And of course, practicalities like availability, cost, and patient contraindications, pacemakers, certain implants, severe claustrophobia can be factors.
And briefly, CT scans, where do they fit in?
Computed tomography CT scans. Their role is primarily when highly detailed bone information is needed, perhaps more detailed than an X-ray provides for complex fractures extending into a joint, or if MRI is contraindicated. They use X-rays and computer processing to create detailed cross-sectional images, showing bones, muscles, fat, and organs with greater bony detail than general X-rays. Their main limitations for sprains and strains are that they are also a static examination, and they generally provide much less detail for soft tissue structures compared to MRI. So they're less ideal for primary soft tissue injury diagnosis unless there's a significant bony component, like assessing the exact position of fragments in an avulsion fracture.
So a hierarchy exists, driven by the clinical question.
Exactly. While imaging is incredibly powerful, It's always a complementary tool. The decision to order imaging, and which type, should always be guided by that detailed clinical history and the precise physical examination findings. For many minor injuries, a full MRI isn't always necessary if good progress is expected with rehabilitation, rest, and activity modifications. However, if a significant tendon tear requiring surgical intervention is suspected, an MRI is often crucial for confirming the diagnosis and planning the operation. Choosing the right modality at the right time for the right question is key.
Once that diagnosis is established, effective management is obviously paramount for optimal recovery and preventing those chronic issues we talked about. Let's begin with immediate care, right in the acute phase. We've all been taught RICE, haven't we? Rest, ice, compression, elevation. But I understand there's a more contemporary evolution to this protocol. Could you elaborate on both and highlight the key differences, especially regarding that shift in thinking for our medical audience?
Absolutely. The management of acute musculoskeletal injuries has indeed evolved significantly in recent years, reflecting a deeper understanding of tissue healing processes and the potential downsides of prolonged rest. The traditional RICE principle, protection, rest, ice, compression, elevation, has been the foundational approach for decades. Its primary aim was, quite reasonably, to minimize bleeding, swelling, and inflammation immediately following an injury, typically within the first 24 to 72 hours.
Can we quickly recap, Bryce?
Certainly. Rest. This involves avoiding putting weight or strain on the injured area. For more severe lower limb injuries, using crutches for the initial, say, 3 to 7 days can be crucial. This aims to prevent further damage, muscle retraction, reduce the formation of a larger muscle gap, and thereby limit hematoma size and subsequent dense scar tissue formation. The idea was simply to cease activities that reproduce or exacerbate pain. Ice. Cryotherapy. We advise applying an ice pack, or the classic bag of frozen peas wrapped in a thin towel, to the injury for maybe 15 to 20 minutes at a time, repeated every 2 to 3 hours, or perhaps in intervals of 30 to 60 minutes. Physiologically, ice significantly reduces local tissue temperature, typically by 3 degrees to 7 degrees C, and can cause a remarkable 50% reduction in intramuscular blood flow. Now, it's not about memorizing those exact numbers, but understanding the principle. Reducing blood flow aims to lead to a smaller hematoma, less secondary hypoxic injury, less inflammation, and potentially accelerated regeneration. Its primary, most immediate benefit, especially in the first 24 to 48 hours, is simply pain control analgesia and reducing that secondary tissue damage from excessive swelling.
Okay. Compression and elevation.
Compression. This involves wrapping the injured area snugly with an elastic bandage, tape, or a compression sleeve. It effectively helps limit fluid extravasation into the tissues, reduces the diffusion of swelling, and provides some mechanical support to the injured joint or muscle. The wrapping should ideally extend from below to above the injured site, but always ensuring it's not too tight to hinder circulation or cause distal swelling or numbness. Elevation. Instructing patients to keep the injured area raised above the level of the heart whenever practical helps reduce hydrostatic pressure. This minimizes the accumulation of fluid in the interstitial space and promotes the drainage of inflammatory exudate back into the lymphatic system, assisting the body's natural clearing process.
Right, that's the RICE we all learned. So what's the evolution? Police.
Yes, the crucial evolution, particularly championed for more active individuals and athletes, is to police protection, optimal load, ice, compression, elevation.
Okay, protection, ice, compression, elevation sound familiar. What's optimal load?
Protection. This remains similar to the rest component of RICE. It's about shielding the injured muscle or joint from excessive loads that could impair or slow the healing process, particularly in the very early stages. This might still involve brief immobilization, crutches, or simply avoiding painful movements. Optimal load. Now, this is the most significant innovation and represents a pivotal shift in thinking, moving away from the idea of complete prolonged immobilization or rest towards a more dynamic concept. While we know that renewed tearing is common if active mobilization starts immediately and aggressively after a severe injury, hence the initial need for a short period of relative immobilization, perhaps with firm adhesive dressings or taping subsequent optimal loading is absolutely crucial for good quality healing.
So not complete rest, but not immediate heavy loading either.
Exactly. This controlled mechanical stimulation, guided by pain and tissue tolerance, actually induces positive changes. It encourages an increase in local vascularization, promotes better regeneration of muscle fibers, and critically, encourages better parallelism and orientation of the regenerating myofibrils and collagen fibers in the scar. This alignment is vital for achieving robust functional recovery and tensile strength. Therefore, rest should not be interpreted as doing absolutely nothing for weeks on end. It means engaging in light, pain-guided activity that encourages healing without causing re-injury or excessive inflammation. I often tell patients, your body isn't broken, it's just temporarily out of order. Gentle movement within limits is like giving it the right signals and tools to fix itself properly, not just letting it scar up stiffly. It's about finding that sweet spot of movement that stimulates healing without causing further damage. Early controlled motion is generally good.
That's a really important shift in emphasis. And what should patients definitely avoid in those first few days?
Yes, it is also important to reiterate what to avoid in that acute phase, typically the first 72 hours, to prevent exacerbating swelling and potentially delaying healing. This includes applying heat, the H in the HARM acronym some people use, so no hot baths, heat packs, or rubs. Avoid alcohol consumption as it can increase bleeding and swelling and impair healing. Avoid running or strenuous activity that stresses the injured part. And crucially, avoid direct, firm massage right onto the injured site initially, as this can increase bleeding, tissue damage, and swelling. So remember, harm, heat, alcohol, running, massage in the first 72 hours.
Harm avoidance. Got it. That leads us nicely to pharmacological considerations. What's the role of medication in managing these injuries, particularly nonsteroidal anti-inflammatory drugs and SAIDs and perhaps corticosteroids? What are the current recommendations, and are we sometimes perhaps interfering with a necessary part of the healing process with some of these drugs?
That's a perceptive question, and it's certainly an area that requires a careful, balanced approach. The literature, particularly for specific muscle lesions in humans, can be somewhat limited in high-quality controlled studies for certain drugs, leading to some debate.
Okay, let's start with NSAIDs, ibuprofen, naproxen, etc.
Right, NSAIDs, nonsteroidal anti-inflammatory drugs. While there are relatively few extensive control studies specifically on NAIDs for muscle lesions in humans, their effects are generally well documented in broader musculoskeletal injury contexts. Short-term early use, typically within the first few days of injury, can result in a transitory improvement in recovery from exercise-induced muscle injuries and can certainly diminish the inflammatory reaction of cells, leading to less pain and swelling. Crucially, studies have generally shown that short-term use does not seem to negatively impact the overall healing process significantly, the tensile strength of the repaired tissue, muscle contraction ability, or retard the proliferation and myotubule formation of those important activated satellite cells needed for regeneration.
So primarily for pain relief early on.
Yes, primarily used for analgesia and managing excessive inflammation in the acute phase, which can help patients manage symptoms and potentially initiate that early optimal loading we just discussed. However, the caution comes with prolonged use. It's important to emphasize that chronic use of NSAIDs, particularly when studied in eccentric contraction models for ligament sprain injuries, appears to be potentially prejudicial. This chronic use has been associated with a subsequent loss of tissue strength and potentially impaired long-term healing. Specifically, some current recommendations advise caution or even suggest avoiding ibuprofen and other NSAIDs for the first 48 hours after injury. The thinking behind this is that they may slow down or blunt the initial necessary healing process by dampening the beneficial aspects of the early inflammatory response too much.
Interfering with the cleanup crew.
Potentially, yes. Remember, inflammation, while causing symptoms, is also a necessary first step in the complex healing cascade. We probably want to manage it, perhaps control excessive inflammation, but maybe not completely abolish it, especially in the very early phase right after injury. Yeah. So short-term use for pain seems okay, but maybe not in the first day or two, and certainly not long-term.
Okay, that's nuanced. What about corticosteroids? Injections, perhaps?
Regarding glucocorticoids, these are generally discouraged in the routine management of acute muscle or tendon injuries due to reported adverse effects on tissue healing. Their use, particularly via injection into or around acutely injured soft tissues, has been associated with delays in the elimination of hematoma and necrotic tissue, significant delays in the regeneration process, and a measurable decrease in the biomechanical strength and integrity of the injured muscle or tendon. They essentially hinder the body's natural repair mechanisms quite significantly.
So generally avoid for acute tears.
Generally avoid for acute muscle and tendon tears, yes. Their role might be considered later for chronic inflammatory conditions like tendinitis, but not typically for acute structural damage.
So for simple pain relief.
For general pain relief, simple analgesics like paracetamol can be used effectively to manage discomfort without the potential anti-inflammatory interference of NSAIDs or the detrimental effects of corticosteroids on healing. Paracetamol often offers a safer first-line option for pure pain management in these acute injuries.
Okay. Once that initial acute phase has subsided, maybe after the first few days, the focus shifts significantly towards rehabilitation, doesn't it? What are the progressive steps involved in rehabilitation to ensure not just healing, but a full and robust return to function? And critically, how do we structure it to prevent re-injury, which is so common? This structured approach seems vital for long-term patient success.
Indeed it is. Once the acute inflammation begins to settle and the tissue enters the repair and remodeling phases, a structured, progressive rehabilitation program becomes absolutely essential. The overarching principle, really echoing that optimal load concept from police, is that all exercises should be initiated pain-free and always preceded by an adequate warm-up for the injured muscle or joint. This avoids exacerbating the injury or causing setbacks. Pain is the critical guide.
Right, pain-free progression. So how does it typically start?
It usually follows a logical progression: early motion and progressive strengthening. You'd often begin with isometric training. These are muscle contractions where the muscle length remains constant, but tension is generated. Think of pushing against an immovable object like a wall, or simply tensing the muscle without moving the joint. Start these gently, without external weights, focusing on just activating the muscle. Then, as tolerated, you can gradually add resistance, perhaps pushing against the therapist's hand. Crucially, all isometric exercises must be performed without pain. If it hurts, it's too much, too soon. These help maintain muscle activation and integrity without significantly stressing the healing fibers.
Okay, isometrics first.
Once pain-free isometric training, even with some resistance, is possible, you can progress to isotonic training. Here, the muscle length changes, while tension is maintained throughout the range of motion. This is your standard weight training, lifting and lowering a dumbbell, using resistance bands through a range. Initially, these exercises should be undertaken without resistance, perhaps just using bodyweight movements through the available range, with the load progressively increased only as strength returns and pain allows. Focus is on controlled movement through the full, pain-free range, and later on maybe isokinetic exercises. These involve movement at a constant speed against a variable, accommodating resistance, often requiring specialized equipment usually found in a physiotherapy or rehabilitation setting. They can be introduced with a minimal load only after the patient can perform isometric and isotonic training painlessly through a full range. They allow for controlled, maximal effort muscle loading throughout the entire range of motion, which can be useful in later stages.
What about flexibility, stretching?
Yes, stretching is very important, but timing and technique are key. Implement careful passive, therapist-assisted, and active patient-performed stretching of the affected muscle. It's particularly important to gently distend the maturing scar tissue during the remodeling phase, when it is still somewhat plastic and malleable, typically starting maybe after the initial week or two, depending on severity. Stretching should be acquired through gradual, sustained strain, perhaps starting with applications of 10 to 15 seconds and progressing to periods of up to 1 minute, always ensuring it remains pain-free. Overstretching too early or too aggressively can easily cause re-injury or increased inflammation. So, patience is key. The goal here is to restore normal flexibility and prevent the scar tissue from becoming tight and restrictive.
And neuromuscular control, balance and coordination.
Absolutely vital. Sensory motor training. This is a critical component, particularly for regaining neuromuscular control and preventing recurrence, especially after joint sprains like ankle sprains, but also relevant for muscle strains. It involves exercises that challenge balance and proprioception, the body's sense of its position and movement in space. This includes things like balance exercises on stable surfaces initially, then progressing to unstable surfaces like wobble boards or foam pads. You can vary the size and shape of the surface, add additional cognitive tasks like catching a ball or naming colors while balancing, and vary visual input, e.g. eyes open versus eyes closed.
Making it progressively harder.
Exactly. Incorporating core stability exercises is also highly recommended to improve overall postural and neuromuscular control, as a stable core provides a strong foundation for limb movement and control. For older individuals, practices like Tai Chi have strong evidence supporting their benefit for improving balance and reducing fall risk. And for athletes who have experienced ankle sprains, progressive balance and agility exercises are absolutely critical for regaining ankle stability and proprioception to significantly reduce the very high risk of re-injury. It's literally retraining the ankle how to react quickly and appropriately to uneven surfaces or sudden movements.
What about hands-on treatments, manual therapy?
Manual therapy can play a role. Specific massage techniques applied appropriately may be beneficial for aiding the drainage of tissues adjacent to the injury site that are not directly compromised, helping to dispose of inflammatory catabolites and reduce swelling. Techniques like cross-friction massage might be used later in the healing process to help remodel scar tissue and reduce adhesions. Functional compressive bandages or taping techniques can also help reduce local pressure, provide support, and optimize the effects of physiotherapy exercises.
And things like therapeutic ultrasound or laser, electrotherapy.
Instrumental physical therapies. These are often used as adjuncts. Therapeutic ultrasound. While the scientific evidence regarding its effectiveness can sometimes be vague or debated for certain conditions, it is widely recommended and used adjunctively for muscle injuries. Its purported benefit is thought to derive from micromassages produced by the high-frequency sound waves, potentially offering some pain relief and promoting cellular activity, though the mechanisms are not fully understood. Other modalities like low-intensity laser therapy, LLT, pulsed ultrasound therapy, and various forms of electroanalgesia, like 10S, may be employed in the early and post-acute stages, primarily for pain and inflammation management. Things like high-intensity laser therapy, HLLT, and continuous ultrasound therapy might be used in later stages, once the tissue is more robust, potentially to stimulate deeper heating, healing, and remodeling. The role of hydrotherapy or aquatic therapy is still somewhat uncertain in terms of specific efficacy for all muscle injuries, although it can be excellent for facilitating early pain-free movement and partial weight-bearing rehabilitation due to the buoyancy effect of water.
Okay. What if things aren't improving as expected after a few days?
That's a crucial clinical checkpoint. If symptoms or pain caused by the lesion have not shown significant improvement by, say, 3 to 5 days after the initial trauma, despite appropriate acute management, the possibility of a large, unresolved intramuscular hematoma or perhaps more extensive damaged tissue than initially thought should be considered. These cases may require special attention, perhaps repeat imaging like ultrasound. And in some situations, puncture or aspiration of a large, tense hematoma under ultrasound guidance may be necessary to facilitate healing by reducing pressure, removing inflammatory fluid, and allowing the body's repair mechanisms to function more effectively.
And just to manage expectations, recovery times.
Yes, it's vital to be realistic. Recovery time from a sprain or strain varies hugely based on the severity of the injury, the specific location, the tissue involved, and individual patient factors like age and activity level. Mild injuries, grade 4 perhaps, often heal within days to maybe a couple of weeks, especially in young, healthy athletes. More significant injuries, particularly partial tears, grade 2, can take weeks to months for full recovery. The paramount importance lies in allowing full quality healing to prevent re-injury. We must guide return to activity based on the patient's symptoms, objective clinical signs, and functional milestones achieved in rehab, rather than strictly adhering to an arbitrary time frame. Working closely with a physical therapist is almost always helpful, often essential, to navigate this progressive return safely and effectively. As a rough guide, most mild to moderate sprains and strains, grade 2, might regain full mobility and function within 3 to 8 weeks, while severe injuries, grade 3 or complex tears, can indeed take many months for full, robust recovery and return to high-level activity or sport. Patience and adherence to rehab are key.
While conservative management clearly yields excellent results for the vast majority of muscle and ligament injuries, there are indeed situations, as you've hinted, where surgical intervention becomes necessary or at least needs serious consideration. When do we, as orthopedic professionals, typically consider surgical intervention for these types of injuries, and what specific considerations guide that decision?
You've hit on a critical point. While conservative management is the mainstay, and very effective for most injuries, there are precise indications where surgical intervention is necessary and can significantly improve outcomes, or is at least strongly considered. These indications are relatively limited compared to the sheer number of injuries we see, but they must not be overlooked. Firstly, large intramuscular hematomas that are clearly not resolving spontaneously with conservative measures. These can cause persistent pain, significant pressure symptoms, impede muscle healing, potentially lead to complications like compartment syndrome in severe cases, or result in dense, restrictive scar formation. Surgical drainage may be required in these select cases.
Okay, non-resolving large hematomas. What about the tear itself?
Yes, the tear itself. Complete lesions or tears, grade 3, particularly if there is little or no associated agonist musculature available to effectively compensate for the lost function. A prime example we discussed is a complete quadriceps tendon rupture without surgical repair. The patient simply cannot actively extend their knee, leading to a major functional deficit. The muscle ends are too far apart to heal spontaneously in continuity. Also, significant partial lesions where more than half of the muscle cross-sectional area is torn. While conservative treatment might still be attempted for smaller partial tears, if over 50% of the muscle belly is disrupted, surgical repair often offers a better chance of restoring near normal strength and function, and
Right.
potentially preventing chronic weakness, pain, and re-tear risk, especially in high-demand individuals.
What about chronic pain issues after an injury?
Good point. Yeah. Cases where the patient complains of persistent pain on muscle contraction or stretch for more than 4 to 6 months, especially if there is an associated objective deficit, like reduced range of motion on extension. This often suggests the formation of problematic adhesive scar tissue that is restricting normal muscle movement or gliding at the injury site. Surgical release of these adhesions, sometimes called tenolysis or myolysis, may be required to restore range of motion and reduce pain. Also, complete tearing of the musculotendinous junction itself, or frank tendon avulsions where the tendon is pulled completely off its bony attachment. These are often clear surgical indications as the mechanical integrity of the muscle tendon unit is totally lost, and the tendon needs to be anatomically reattached to the bone, often using suture anchors to restore function.
And lacerations. Cuts.
Yes, muscle lacerations resulting from direct trauma against sharp surfaces. While these are technically demanding repairs and perhaps have a higher likelihood of complications or clinical failure compared to repairing indirect stretch tears due to the nature of the damage and potential contamination, repair may still be attempted depending on the functional importance of the specific muscle involved and the extent of the laceration.
Okay. Any general principles for the surgery itself?
Regarding general principles of surgical techniques, various suture configurations have been described in the literature. The trend is towards using configurations that are resistant to traction and tensile loading, aiming to minimize the risk of the sutures pulling out from the often softened or weakened muscle or tendon tissue. Techniques like locking stitches or incorporating suture anchors are common. It's also important to emphasize that meticulous incorporation of the epimysium, that's the tough connective tissue sheath surrounding the entire muscle, significantly improves the biomechanical properties and strength of sutured muscle bellies, providing the stronger, more robust repair construct.
And post-op care.
Post-surgical care is just as critical as the surgery itself, of course. The repaired muscle or tendon must be protected, typically by means of an elastic bandage for compression, and often some form of immobilization like a brace or cast, to promote relative immobility initially and protect the repair. The duration and type of immobilization naturally depend heavily on the severity and location of the trauma and the perceived strength of the repair. For example, patients with repaired complete tears of the quadriceps or gastrocnemius muscles are typically instructed not to put any weight on the limb for at least 4 weeks, sometimes longer, to allow for initial healing and revascularization of the repair site before starting gradual mobilization. Surgical repair in cases of wide muscle failure, or where portions of the muscle might be denervated, can also potentially increase the chance of reinnervation and help avoid the development of that thick, debilitating scar tissue that can severely compromise long-term function.
But surgery isn't always the answer, even for complete tears.
That's right. It is important to acknowledge that despite excellent results often being reported after surgical repair of certain complete lesions, particularly tendon avulsions, the evidence in favor of routine surgical management for all muscle injuries, even all grade 3 muscle belly tears, is still considered somewhat scanty or debated in the literature. For many grade 3 injuries, particularly mid-substance muscle belly tears, medium to long-term functional outcomes are often found to be quite similar, whether treated surgically or with an appropriate period of immobilization followed by intensive structured physical therapy. The decision often boils down to a careful consideration of specific patient factors: age, activity level demands, the particular muscle group involved, the precise nature and location of the tear, for example, tendon versus muscle belly, degree of retraction, and increasingly shared decision-making with the patient after discussing the potential risks and benefits of each approach.
Right. Let's move into some specifics now. This section is critically important for our listeners actively practicing in orthopedics. Let's delve into some specific muscle groups that are frequently affected by these injuries and discuss their unique clinical presentations, diagnostic challenges, and particular management considerations. Shall we start with quadriceps muscle injuries, particularly those distal lesions near the knee?
Yes, certainly. Quadriceps muscle injuries, particularly distal lesions involving the quadriceps tendon attachment onto the patella, are relatively uncommon compared to, say, hamstring strains, but they can be quite debilitating because they knock out the primary knee extensor mechanism. They tend to occur most often in individuals over 40 years of age, though they can certainly happen in younger high-impact athletes too.
What's the usual mechanism?
The typical mechanism can sometimes be direct trauma, like a fall directly onto the front of the knee. But it's classically reported as a result of a forced eccentric contraction, that sudden, powerful contraction while the muscle is lengthening. Often happens when an individual stumbles and attempts to restore balance during a fall, with the lower limb in a position of slight flexion, generating immense tension across the quadriceps and its tendon, causing it to fail. Interestingly, spontaneous and even bilateral tears have also been described, particularly in athletes or patients with underlying systemic metabolic disorders, such as chronic renal failure, diabetes, or hyperparathyroidism, or sometimes in cases of chronic steroid use, which is known to weaken tendon tissue over time.
How do these patients typically present?
In terms of clinical presentation, patients usually present with acute, sharp pain felt just above the patella, often after a specific incident, like a stumble or fall. They're frequently incapable of remaining standing upright, unaided, immediately after the fall, especially if it involved knee flexion, as they can't actively lock or extend the knee. During the physical examination, the absolute hallmark sign is an inability to actively extend the knee against gravity. You ask them to lift their straight leg off the bed, and they just can't, or there's a significant lag. Often, a palpable interval or gap can be felt just above the superior pole of the patella. This is what we refer to as the sulcus sign, or gap test. Feeling that gap is a crucial clinical finding, strongly indicating a complete tear.
But they can still bend the knee.
Yes, usually. Despite this inability to actively extend, patients are typically capable of actively flexing the knee, as the hamstring muscles are intact, and they usually have full passive flexion and extension when examined by the clinician, although attempting active extension is impossible or results in only the patella moving slightly without lower leg extension.
And diagnosis, mostly clinical.
For diagnosis, it's primarily based on these compelling clinical findings, especially that active extension lag and the palpable gap. Simple radiography, X-rays, is an inexpensive initial tool. While it doesn't directly show the tendon tear, it can reveal indirect signs such as soft tissue edema anteriorly, perhaps a joint effusion, sometimes calcification within the tendon remnant in chronic cases, or even a low-lying patella baja, if the tendon has ruptured and retracted significantly. Ultrasound is also an inexpensive and useful method for diagnosing these lesions due to their relatively superficial location, often clearly confirming the tear and giving an idea of its extent and retraction. However, magnetic resonance imaging, MRI, is particularly useful for getting a better, more detailed view and for precisely defining the location and extent of the lesion. It provides crucial anatomical details like the quality of the remaining tendon tissue and the exact amount of retraction, which are very important for proper preoperative workup, especially if surgery is being considered.
And treatment. Usually surgical for complete tears.
Regarding treatment, yes, for complete quadriceps tendon tears, surgical intervention is generally indicated because of the significant functional deficit caused by the loss of active knee extension. Non-operative treatment simply doesn't work for these. It's strongly emphasized in the literature that early surgical treatment, ideally within the first couple of weeks, is associated with significantly better functional results. It makes the repair technically easier, as the tissues haven't scarred down or retracted excessively, and it leads to better muscle recovery. Conversely, any significant delay in carrying out the surgical repair is linked to potential complications, like prolonged periods of physiotherapy being needed, difficulty regaining full knee flexion due to scarring, and sometimes a persistent loss of full knee extension power due to quadriceps muscle retraction and atrophy during the delay. After surgical repair, patients typically remain with the knee immobilized, often in or near full extension in a brace or cast, for around 4 to 6 weeks to allow for initial tendon healing and protect the repair before starting gradual range of motion and strengthening exercises.
Okay, let's move posterior now. Hamstring injuries, practically endemic in many sports, aren't they? High recurrence rates, too. What are their unique characteristics and management considerations, particularly given how common they are?
Yes, the hamstring muscles are notoriously susceptible to injury, accounting for a huge proportion of sports-related muscle injuries, particularly in sprinting and kicking sports. As we touched on earlier, they are among the least flexible muscle groups of the lower limb in many people, and they are particularly vulnerable to injury during powerful, eccentric muscle contraction. The severity of a hamstring injury is also often initially neglected or underestimated, especially during the acute phase by the athlete themselves. And yes, they are indeed the commonest muscle injury among athletes, especially in sports involving high-speed running like football, rugby, track and field. And you're right, re-injury rates can be frustratingly high, sometimes quoted as high as 30% or more within the first year if the initial injury isn't managed correctly and rehabilitation isn't completed fully.
How do they typically present clinically?
Clinical presentation for these injuries is usually diagnosed from a high degree of clinical suspicion based on the mechanism, combined with a careful clinical examination. Patients typically report a sudden onset of sharp pain in the posterior thigh, often feeling a distinct pop or pull or snap during the causative movement, like sprinting or stretching.
Yeah.
They may immediately stop running or activity, often clutching the back of their thigh. Pain is usually reproduced with resisted knee flexion, as the hamstrings are primary knee flexors, and sometimes resisted hip extension. Passive stretching of the hamstrings, like a straight leg raise, also typically reproduces the pain, often quite sharply at a specific point. Tenderness is usually well localized on palpation.
And imaging, is MRI usually needed?
For diagnosis, magnetic resonance imaging, MRI, is highly valuable, particularly for anything more than a minor grade A injury, or if the diagnosis is unclear. It's excellent for differentiating between complete and incomplete lesions, for precisely defining the exact location of the tear. For example, is it in the biceps femoris, which is most common, or the semitendinosus or semimembranosus? Is it proximal near the ischium, mid-belly, or distal near the knee? It also shows the grade of the tear and the degree of any retraction. This precise anatomical information is crucial for planning the appropriate treatment strategy, whether conservative management is appropriate or if surgery should be considered, particularly for proximal avulsions. It's also very helpful for predicting likely return-to-play timelines, as proximal tears or those with tendon involvement typically take longer to heal.
And treatment options, conservative versus surgical.
Treatment for hamstring cases ranges widely. The vast majority are managed conservatively, particularly grade 1 and 2 injuries, and even some grade 3 mid-substance tears. This involves the police protocol initially, followed by a carefully progressed rehabilitation program. A key focus in hamstring rehab is restoring strength, particularly eccentric strength, flexibility, and neuromuscular control to prevent re-injury. Surgical repair is typically reserved for specific cases, most commonly complete proximal hamstring tendon avulsions, where 2 or 3 of the tendons have been pulled completely off their attachment on the ischial tuberosity, the sitting bone. Surgery is also sometimes considered for large, retracted distal tendon tears. While surgical repair carried out at a later time may still yield reasonable results, particularly for these bony avulsion injuries, early repair, again ideally within a few weeks, is generally preferred if surgery is indicated. This enables faster functional rehabilitation and can potentially help avoid complications like chronic pain, weakness, or even neurological symptoms, such as gluteal sciatica, which can occasionally arise from delayed intervention if a large hematoma or the retracted scarred tendon irritates the adjacent sciatic nerve. It's worth noting that complete tearing of all 3 hamstring muscles proximally right off their origin is relatively rare compared to strains, but it's a very significant injury when it occurs, often requiring surgical reattachment for optimal functional outcome, especially in active individuals.
Okay. And what about injuries to the adductor musculature? Groin strains, often associated with debilitating groin pain, especially in kicking sports.
Yes, the adductor muscle group, the muscles on the inside of the thigh, plays a vital role, acting in conjunction with the lower abdominal muscles to stabilize the pelvis and control leg movement, especially during activities involving adduction, like kicking or cutting and changing direction.
What predisposes athletes to these?
Mechanism and predisposing factors. Athletes who participate in activities requiring repeated forceful kicks, like football or martial arts, sudden spurts of speed, or frequent rapid changes of direction, like ice hockey or tennis, have a significantly greater incidence of chronic pain in the region of the adductors, often termed groin pain, or, more broadly, athletic pubalgia. There's clear evidence suggesting that athletes with pre-existing weakness of the adductor muscles relative to their abductors, the muscles on the outside of the hip, creating a muscle imbalance, and also those with diminished hip range of motion, particularly limited abduction or internal rotation, are more likely to develop adductor-related groin pain during their playing season. This underlying muscle imbalance and potential lack of flexibility seem to be key predisposing factors.
How do they present? Is it always an acute tear?
Clinical presentation. Not always acute. Patients typically present with discomfort, felt deep in the region of the groin, or sometimes more distally as medial thigh pain. A specific triggering factor, such as a sharp kick or a sudden stretch during a slide tackle, may be reported in acute tears. However, in more chronic cases, the onset might be insidious, with pain gradually worsening over time. On physical examination, pain is typically elicited on palpation, often with focal tenderness right at the adductor origin on the pubic bone, particularly the adductor longus enthesis. There might be some focal edema along the adductor muscles in acute cases. You'll also usually find diminished adductor muscle strength on testing and significant pain upon performing resisted hip adduction exercises, the classic squeeze test, especially when compared to the unaffected side.
Diagnosis straightforward.
Diagnosis. The diagnosis can frequently be made from the findings of the physical examination alone, particularly in typical presentations with a clear mechanism, if acute, and that specific point, tenderness and pain on resisted adduction. Nevertheless, magnetic resonance imaging, MRI, sometimes with contrast, can be very useful. It helps to confirm the diagnosis, precisely localize the tear or inflammation, grade the severity, and importantly helps in making a differential diagnosis between other causes of groin pain, such as pubic osteitis, inflammation of the pubic symphysis itself, stress fractures, or a sports hernia, which typically involves weakness or tearing in the posterior inguinal wall.
And treatment, mostly conservative.
Treatment. Yes, the initial treatment for most adductor strains, even relatively significant ones, is typically conservative. This involves rest from aggravating activities, ice, compression sometimes, and a well-structured, graded rehabilitation program. The rehab must progressively strengthen the adductors, address any underlying muscle imbalances, often strengthening core and abductors too, and restore hip mobility. Infiltration of the emphysis, that attachment point, of the long adductor muscle with local anesthetic and perhaps a small dose of corticosteroid may be considered for refractory cases that are resistant to initial conservative measures. This can provide temporary pain relief and potentially break the pain cycle, allowing for more effective engagement with rehabilitation. In cases of acute complete tears, especially significant avulsion injuries where the tendon pulls off the bone, open surgical repair, often involving placing suture anchors into the bone and reattaching the tendon, has been described with generally reported good results, particularly in high-level athletes wanting to return to sport. Patients are typically cleared to return to their sport only after their hip strength and range of motion have returned fully to their previous pre-injury pattern, and crucially, after the complete resolution of the painful state during sport-specific activities. Because a predisposition to adductor injury is often caused by those underlying muscle imbalances, a significant part of the long-term management involves paying careful attention to ongoing strengthening and conditioning of the entire hip and core musculature to prevent new lesions.
Finally, let's discuss gastrocnemius muscle injuries, the calf muscle, commonly known as tennis leg, which, as you mentioned, can often be confused with other, potentially more serious conditions like DVT.
Yes, the gastrocnemius muscle, the main bulky muscle in the calf. Like the hamstrings and quadriceps, it has a propensity for injury because it traverses two joints, the knee and the ankle, making it vulnerable during complex movements involving both joints simultaneously. It's a powerful plantar flexor of the ankle and also assists in knee flexion. Interestingly, the medial head of the gastrocnemius is statistically more commonly injured than the lateral head, likely due to its higher activity level during propulsion and its larger muscle mass.
And that crucial differential diagnosis.
Yes, a critical differential diagnosis for any acute calf muscle pain that we must always consider and actively rule out is deep vein thrombosis, DVT, along with superficial thrombophlebitis. The clinical signs, pain, swelling, tenderness in the calf can overlap significantly with a muscle tear, and obviously missing a DVT can have life-threatening consequences due to the risk of pulmonary embolism. This is where timely imaging, particularly diagnostic ultrasound, becomes absolutely crucial.
And the term tennis leg.
Yes. The term tennis leg has historically been used to describe acute pain and injury, specifically in the calf, often at the musculotendinous junction of the medial gastrocnemius. This condition is classically attributed to the forceful serving movement in tennis, which involves sudden, full extension of the knee, together with abrupt dorsiflexion of the ankle, a position that puts maximum eccentric stretch on the calf. This often results in a sudden, sharp pain. However, it's important to note this injury isn't exclusive to tennis players. It's commonly described in middle-aged recreational athletes, weekend warriors, during periods of strenuous exercise in other sports like basketball, squash, running, especially hill running or sprints, and even sometimes during weight training, essentially any activity involving a sudden acceleration or forceful push-off from the foot.
How does it present?
Clinical presentation. The pain typically appears very suddenly, often described dramatically by the patient as feeling like they've been kicked in the calf or shot, or feeling a sharp pop or tearing sensation. This is usually accompanied by focal edema, swelling, and often subsequent ecchymosis, bruising, appearing in the calf over the next day or two. Patients often report immediate difficulty bearing weight fully on the affected leg or pushing off during walking, While classically described as an injury of the distal muscle tendon junction of the medial head, more proximal lesions within the gastrocnemius muscle belly can also occur. A specific area of tenderness is usually palpable, and sometimes, particularly with more significant tears, a palpable gap or defect can be felt in the muscle.
Diagnosis usually straightforward with ultrasound.
For diagnosis, yes, due to the relatively superficial nature of the gastrocnemius muscle, ultrasound evaluations are generally highly reliable. This modality makes it relatively easy and quick to confirm the muscle tear, assess its location and size, and crucially, to rule out the presence of deep vein thrombosis, which is essential. Ultrasound can also facilitate image-guided aspiration of any significant fluid accumulations, like large hematomas, if they are causing excessive pain or pressure, which can provide symptomatic relief and potentially aid healing. MRI can be used for more detailed assessment if needed, perhaps if the diagnosis is unclear or if a more proximal or complex injury is suspected. But often ultrasound is sufficient for diagnosis and initial management planning, especially given its ability to rule out DVT quickly.
In treatment, conservative again.
Treatment. Yes, the treatment for the vast majority of gastrocnemius lesions, even quite significant tears, is conservative. This typically involves the police protocol in the acute phase, often with a period of partial weight bearing using crutches, and sometimes a heel lift in the shoe to reduce tension on the calf. This is followed by a structured, progressive rehabilitation program focusing on regaining ankle range of motion, especially dorsiflexion, calf muscle strength, both gastrocnemius and the deeper soleus muscle, endurance, and eventually a gradual return to impact activities. Surgery is only occasionally undertaken for gastrocnemius tears, typically reserved for very specific indications such as needing to drain very large, persistent hematomas that are causing significant pain or compartment pressure symptoms, potentially repairing confirmed grade 3 lesions with very wide retraction, although this is uncommon and debated, or needing to perform a surgical compartmental decompression in the rare but serious cases of acute compartment syndrome developing within the calf compartments due to massive swelling after the injury. But for most typical tennis leg injuries, conservative management is the way to go.
Right, let's switch focus now towards prevention and the future. Beyond the complexities of diagnosis and treatment that we've covered in such detail, what practical advice can we offer our patients and athletes to proactively reduce their risk of sustaining these common, yet often quite debilitating musculoskeletal injuries in the first place? Prevention, after all, is always better than cure, isn't it? Especially with those high recurrence rates we see.
Absolutely. Prevention is a cornerstone of good orthopedic and sports medicine practice, and it's where we can truly empower our patients to take control of their musculoskeletal health. We can certainly offer several practical, evidence-based strategies to help minimize the risk of sustaining sprains and strains. Firstly, and perhaps most importantly, comprehensive physical conditioning. This is absolutely paramount. It's not just about being fit in a cardiovascular sense. We need to recommend regular mobility and flexibility exercises. Things like dynamic stretching before activity, static stretching after, or incorporating practices like yoga or Pilates can be very beneficial. For instance, poses like downward-facing dog are excellent for improving calf and hamstring flexibility, which is crucial for preventing strains in those muscle groups. Equally important is emphasizing regular strength training, whether that involves using weights, resistance bands, or even just bodyweight exercises, to build robust, resilient musculature around the joints. Strong muscles act as better shock absorbers and provide dynamic joint stability. And it's crucial within that to highlight the importance of addressing muscle imbalances. We often see situations where one side of the body, or one muscle group, like the quadriceps, is significantly stronger or tighter than its opposing group, like the hamstrings. These imbalances create abnormal stresses and are a major predisposing factor to injury on the weaker or less flexible side. So balance training is key.
Okay, conditioning is number one. What else?
Secondly, balance training. This is often overlooked but very important, especially for preventing falls and joint sprains. Advise incorporating specific balance exercises into their routine. Simple acts like standing on one leg while brushing teeth or progressing to standing on less stable surfaces can be effective. For older individuals, practicing Tai Chi has strong evidence behind it for improving balance and significantly reducing fall risk. And as we discussed, for athletes who have previously experienced ankle sprains, progressive balance exercises are absolutely critical. They help regain ankle stability and retrain proprioception, that sense of joint position and movement, which significantly reduces the risk of re-injury by helping the ankle react faster and more appropriately to instability.
Makes sense. What about how people increase their activity levels?
Thirdly, gradual activity progression. This is a huge factor in overuse injuries. We must stress the importance of avoiding increasing physical activity levels, whether that's intensity, duration, or frequency, too quickly. A classic example, as you know, is the person new to running who suddenly decides to train for a half marathon with only a month to prepare. That's asking for trouble. Instead, advocate for a slow, gradual ramping up of activity, allowing the body's tissues, muscles, tendons, bones to adapt progressively and build tolerance without being overloaded. The general 10% rule, increasing total training volume by no more than 10% per week, is often cited as a reasonable guideline, though individual adaptation varies.
Good rule of thumb. Equipment.
Fourth, proper equipment. Seems obvious, but it matters. Insist on patients wearing appropriate, well-fitting, and supportive footwear for their specific activity. Running shoes wear out and lose their cushioning and support over time, significantly increasing the risk of lower limb injuries. Ensure any sporting equipment, like braces if needed, pads, or even things like bike setup, is appropriate and well-maintained to provide adequate support and protection.
Warm-ups and cool-downs. Still important.
Fifth, warm-up and cool-down. Yes, still fundamentally important. Emphasize the necessity of performing thorough warm-up routines before any intense physical activity. This should aim to gradually increase heart rate, blood flow to muscles, and muscle temperature, preparing them for the demands ahead. This might involve light cardio followed by dynamic stretches relevant to the activity. Likewise, performing cool-down stretches after activity is important to aid recovery, potentially reduce muscle soreness, though evidence on this is mixed, and crucially, maintain or improve flexibility over time.
Listening to your body.
Sixth, rest and recovery. Absolutely essential. Advocate strongly for listening to the body's signals fatigue, persistent soreness, and allowing sufficient time for rest and recovery between exercise sessions or intense activities to prevent overuse injuries. Tissues need time to repair and adapt. For competitive athletes, this often means actively scheduling regular rest days, perhaps 1 to 2 days each week, for complete rest from their specific competitive sports and training, and also taking planned breaks or off-seasons from a specific sport during the year to allow the body to fully recuperate and rebuild, both physically and mentally. Overtraining is a very common pathway to injury. Seventh, proper technique. Encourage learning and consistently using proper technique and form for all activities, whether it's lifting heavy objects correctly in an occupational setting using legs, not back, jumping and landing mechanics in basketball, or executing sport-specific movements like a golf swing or swimming stroke. Incorrect biomechanics place undue, abnormal stresses on joints and muscles, significantly increasing injury risk over time. Sometimes seeking guidance from a qualified coach or physical therapist to assess and correct technique flaws can make a massive difference in injury prevention.
Weight management.
Eighth, maintain a healthy weight. Explain sensitively, of course, that carrying excess body weight can put significant additional unnecessary pressure and stress on weight-bearing joints, like hips, knees, ankles, and associated muscles and tendons. This increases the risk of both acute injuries and the development of chronic conditions like osteoarthritis. Maintaining a healthy weight reduces this mechanical load.
And finally, addressing previous injuries properly.
And ninth, yes, address previous injuries adequately. This is critical for breaking the cycle of recurrence. If a patient has a history of sprains or strains, advise them that the previously injured area may well be weaker, less stable, or have altered proprioception, making it inherently more prone to future injuries. This is a crucial discussion to have. Suggest considering the judicious use of external supports like an elastic bandage or a functional brace to provide additional support during high-risk activities, but emphasize this shouldn't replace proper rehab. And strongly recommend engaging fully in and completing a physical therapy program designed to specifically strengthen the weakened muscles around the joint, restore full range of motion, improve neuromuscular control and proprioception, and ultimately enhance the overall stability and resilience of the area. Ignoring a past injury or cutting rehab short is often a recipe for future problems.
That's excellent, comprehensive, practical guidance. A lot for patients and athletes to work on there. Now, looking forward, the field orthopedics is ceaselessly pushing boundaries, isn't it? With new research constantly emerging. What new therapeutic options or perhaps research directions are showing promise for the future treatment of muscle and ligament injuries, even if they're still largely investigational or not yet mainstream?
Yes, this is indeed an exciting area of ongoing research constantly evolving. And while many of these approaches are still perhaps investigational or just emerging into clinical practice, they hold significant promise for potentially improving the outcomes of muscle and tendon injury treatment in the future.
Like what, for example? Growth factors, stem cells.
Exactly. One key area is biological augmentation using growth factors and potentially gene therapy. We know that various growth factors and cytokines act as potent signaling molecules. They're mitogenic activators for various cells, including those crucial muscle precursor cells, the satellite cells, during the regeneration phase after injury. This makes them theoretically promising therapeutic options for assisting or accelerating the recovery of skeletal musculature, perhaps by delivering them directly to the injury site to actively promote tissue growth and better quality repair. The idea is to amplify the body's natural healing signals or provide missing ones. Gene therapy also holds considerable theoretical potential, perhaps by using vectors to deliver genes that code for specific growth factors directly into the cells at the injury site, providing sustained local production. Initial steps have been taken in preclinical research, but extensive future studies are obviously needed to determine its clinical reality, safety, and efficacy due to the complexities involved. Then, as you mentioned, stem cells. Recent research has indicated that in response to significant muscle injury, it's not only the local specific tissue cells, like satellite cells, that participate in the repair process, but also potentially circulating or other non-muscle stem cells might be recruited to the site. This opens up the immense potential for stem cell-based therapies, where mesenchymal stem cells, for example, could be harvested, potentially expanded, and then introduced back into the injury site to directly contribute to muscle regeneration and improve healing outcomes. The concept is that these pluripotent or multipotent cells could differentiate into new muscle fibers or supporting cells, offering true regeneration rather than just scar-based repair. This is still largely in animal models or very early human trials for muscle injuries, but the theoretical potential is vast.
What about PRP? That seems quite widely used already.
Yes, platelet-rich plasma, PRP products. These have certainly gained significant popularity and are widely tested and used across various medical fields, including orthopedics, for muscle and tendon injuries. The rationale is that these products contain a much higher concentration of platelets than normal whole blood. And platelets, as we know, contain various granules, alpha and dense granules, that release a whole cocktail of growth factors and other bioactive modulators when activated. These are believed to initiate and positively influence the natural healing cascade, impacting inflammation, cell proliferation, and tissue remodeling. However, it's crucial to acknowledge that while PRP products may theoretically promote healing by delivering this concentrated dose of growth factors, their exact mechanism of action in vivo is still not fully understood. And critically, the current clinical evidence base supporting their widespread routine use, particularly for acute muscle tears, is often of low quality, with many studies being small, poorly controlled, having heterogeneous results, and using different PRP preparation methods.
So the jury is still out on PRP for muscle tears.
I think that's fair to say for routine use in acute muscle tears. We desperately need more appropriately powered, high-quality, level I randomized controlled clinical studies using standardized preparations and relevant functional outcome measures with adequate long-term follow-up to truly validate their widespread use and understand which specific injuries our patients might benefit most. Until then, it's perhaps best considered an adjunctive treatment in specific circumstances rather than a proven panacea.
Any other drugs on the horizon? You mentioned losartan earlier.
Yes, an intriguing development is the potential use of losartan. This is actually an established antihypertensive drug and angiotensin II receptor blocker. It has reported some encouraging results in preclinical studies, sometimes when combined with PRP, for muscle injury. Losartan appears to act, at least partly, by counteracting the process of fibrosis, that excessive scar tissue formation which can be problematic after muscle injury. By mitigating this fibrosis, it seems to promote better healing by stimulating regeneration and angiogenesis, the formation of new blood vessels, hopefully leading to a more functional, less restrictive scar. A specific and interesting finding from some animal studies is that losartan seems to be most effective if its administration is started not immediately right after the injury, but rather delayed slightly, perhaps starting 3 to 7 days after the traumatic event. This might suggest a specific therapeutic window, perhaps allowing the initial necessary inflammatory phase to proceed before modulating the subsequent fibrotic response. Again, more research, particularly human clinical trials, is needed here.
Fascinating. Lots of potential avenues.
Indeed. In conclusion, while these new biological and pharmacological perspectives offer genuinely exciting possibilities and represent the cutting edge of research into muscle injury treatment, it's important to reiterate that there is still relatively limited robust scientific validation from large-scale human trials to support their routine clinical use across the board just yet. Continued rigorous research is absolutely essential to solidify their role, understand their optimal application, and ensure their safety and cost-effectiveness in everyday orthopedic practice for muscle and ligament injury treatment.
To summarize this really insightful deep dive, then, we've meticulously distinguished sprains affecting ligaments from strains affecting muscles and tendons. We've explored the granular details of injury classification, from the basic grades to more nuanced systems. And we've illuminated the body's intricate, intrinsic repair mechanisms, that fascinating dance of destruction, regeneration, and scar formation. We've critically examined the indispensable role of a thorough clinical assessment, including those vital red flags, and the complementary power of advanced imaging modalities like ultrasound and MRI. And we've navigated the evolving landscape of management, from acute care principles like RICE and police, through pharmacological considerations, and into the crucial phases of progressive rehabilitation, including specific considerations for common, yet often complex, muscle injuries like those affecting the quadriceps, hamstrings, adductors, and gastrocnemius. Ultimately, it seems a comprehensive, nuanced understanding of these common musculoskeletal injuries is absolutely paramount for effective diagnosis and truly tailored treatment. This ensures not only the best possible immediate outcomes, but also promotes better long-term functional success for our patients in everyday orthopedic practice. And perhaps, as we've explored this intricate balance between destruction and repair at the tissue level, it leaves us with a critical question to reflect on in our own practice. Are we consistently optimizing the body's remarkable innate healing potential with our interventions? Or are there times when we might, perhaps inadvertently, be standing in its way? Definitely something to consider in your next clinic. Professor, thank you so much for sharing your invaluable insights and deep expertise on this crucial and complex topic today. It's been incredibly informative.
It was my genuine pleasure. Thank you for having me.
And to you, our dedicated listener, if you found this deep dive valuable, please do consider taking a moment to rate and perhaps share this discussion with a colleague. It really helps us reach more dedicated professionals like yourselves. Until next time on The Deep Dive, keep delving deeper.